It's a little messy.
Go over. So all year we've been learning about how to
We're ready.
review literature. I've been trying to give you guys a toolkit that you can quickly apply to paper, get the most relevant information out of it, and sort of form an opinion on whether it should influence your clinical practice. So today we've been doing this for like 8-9 months. We've been over quite a few things. So this is going to be like a practical application of it. So I actually brought 6 articles that you may or may not have seen. And then we're going to split up into either pairs or 3, depending. And then I'll set a timer. I'm going to split it up and figure out, a question sheet to prompt reviewing the article. So the idea is to just quickly read it, get what you need, make a decision, form an argument. And then Dr. Henthorn and I are going to try and break it and try and challenge you. And it started out as sort of like a workshop, but I think we should do like battle royale style journal club. So you make the case as to why this should or should not change your practice. And then Tom and I will take the opposing view, and then if you want to jump in too and be on the team faculty. And then the group will just say who won the journal club standout. Or we can just do it a boring way. But I thought it'd be more fun to make it.
Are there prizes?
Not yet. So I was thinking about prizes, and that would be for June if we do this again. But that might be a good way to go forward. Everyone up for the game version, or do you want to do the boring version?
When you put it that way.
Okay. Also, next question, do you want me to randomly pass out the papers, or do you want to pick?
There's only 8 of us, so...
Okay. I'll shuffle, and then whichever one you end up with, that's your group. And I have electronic versions for us if you guys want to take a look. I'm sort of familiar with these since I've used them before, so.
How's there only 8 of us?
To have seen them yet, and I was a little insulted that Nate thought I hadn't read the entire literature.
All the topics. You haven't finished the internet yet, Tom?
No.
You haven't done a flash
Don't take
for somewhere?
No.
So 6. How many people are here?
9.
We do not have very many residents here.
Fine.
This is our
So
medical,
2.
this is our medical student.
No, you're in.
You count. You're a person. You count.
I did take a sandwich.
I wasn't counting her.
Should we stick to?
Yeah, I think I'll eat the sack.
Oh, and then here's the, these are the prompts. So I think these are sort of like the bare minimum for your argument. Sort of using what we've gone over just as a reminder. You can write those down and then go over it. You will need to find your pair, whatever, so you guys can.
Luke, any of these or?
I don't know. We did it.
Papers you guys got.
Remote ischemic preconditioning.
Oh, look, there's 11. We got these too. Oh, yeah. Remote ischemic preconditioning and outcome cardiac surgery.
Got one of that.
These
So
are
it's like go fish. You have to leave the other people.
Well, we found each other.
Yeah, that was just really lucky.
We fished.
I didn't shuffle that well, and there's not that many. You got those? Yeah.
That's that article we're doing this one on.
That one's yours? Yeah. Okay, that's a good one. That one's fresh. That was last week.
All right.
Ooh, a freshie.
Fresh.
Oh, look, there's another person. There's 12.
Limitations.
Everyone's good.
I don't think I sent it. Yeah, you were supposed to read it now.
It's just groups of 2, Glenn.
You gotta
Just
find
groups of 2.
Pick a random paper. There's 6.
Our medical students.
Just groups of 2, buddy.
I've got my group.
Oh,
Just 2.
pretty sure just
Alright.
trying to get in your group.
On the screen.
What?
What
I don't know. What group are you in?
Tom, are you in our group?
It'll be a group of 3.
Yeah.
He's a schemic. It's
12 people.
You have a schemic preconditioning.
And 6. 12 divided by 6. Yeah, you're right.
Group
That's
of 3. We gotta reshuffle.
Thank you. I might be
You want to do all of them?
We got
My
a group
bad.
of 3.
You gotta pick preconditioning kidney injuries.
Remote ischemic preconditioning.
All kinds of
Actually,
global
let's see, there's a group of 2.
Right.
Assign me there.
Yeah, we'll sign you.
Come over this one.
But you guys are 2 and 2, or?
I think I've read this.
For And then that's 3.
Yeah, this seems familiar.
Oh, what happened to Tom? Tom is a 1?
Yeah.
Tom's by himself.
I've got ischemic preconditioning kidney injury.
The JAMA
That doesn't sound very.
Get over there, guys.
Nice try.
Womp womp.
Well, we have ischemic preconditioning and cardiac surgery, so same thing.
It's targeted. It isn't.
It is. One's good, one's bad.
Cardiac
What do you
surgery.
do?
Undergo cardiac surgery.
Okay. There's some
I
left
need a
over.
pen. Sick Nicky, can I
Okay,
have
so
a
these
pen?
are the ones.
Thick Nicky.
We came up with a new superlative for you today.
Wait, oh, spoiler.
So intraoperative prosthodontics, is that what they
No
did?
longer least likely to be
No, I didn't know we did that.
Does normal saline kills people?
most likely to rollerblade. And I'm
I did date a girl in college who rollerbladed. She rollerbladed into the cafeteria one time with me and my friends were sitting there. And I like almost
There's a retrospect.
I was like, and then we broke up like pretty soon.
Why?
Swear to God.
Rollerblade into the hospital.
Specifically, like, where did they run it at?
You know, have my little like skid stop. Like,
Yeah.
Yes.
you guys don't have me pegged
Read
to the
faster.
wall. Most likely to rollerblade in my ass. Am I right, Tom?
It's like, I rollerblade.
0.2 to 0.6 mics per kilo per
Yeah, don't worry
hour.
about it.
After bypass,
Hello?
and continued for less than 24 hours postoperatively in the ICU.
All right, so what's the plan? Stan?
3 non-ischemia.
Oh.
Kept on it.
Get to read those, I guess. I'm gonna get another piece of paper for us.
Before, right?
Ask some questions.
Oh yeah, oh my god, do whatever you want. I know, it looks super gross now.
What do you need to know to understand the study? Methods that use, results, strengths, limitations. Change your practice. Why?
Yeah, they were going right there.
There they are. Okay.
So the patients who didn't receive DEX, what did they?
Or just nothing.
Reducing sensory after myocardial injury.
Sounds like it was less faster.
It is now. Yeah.
I was wondering.
Yeah.
It's like, where's the question? Where's the article? So. What do I need to know?
Blah, blah, blah.
Well, first I need to know English. So
Did you read it already?
No, it's basically like what is the article?
Yeah, I don't know.
So,
Maybe they just want to replicate it.
But at least it's strong. So I guess we'll have to probably write it.
Retrospective, yeah.
Well, too, is it?
So you guys
Publish it
get
every
like 15 minutes to get your arguments ready. And then we'll try and break them after that.
I mean, so they didn't show decrease
We'll try to-
injury, but maybe not.
So what?
How their clinical.
Talk it like it's
Yeah.
talk about it like it's an RCT. It's actually
RCT,
Retrospective.
multi-center, controlled with a sham procedure.
Blah, blah, blah.
Patients in the Precedex didn't actually had a rating incidence of
Yeah,
a
so
history
it's
of
just
congestive heart failure,
They were
low
sicker
gas,
for
so
some
they were
reason.
sicker.
Well, these are
They
high
didn't
risk
have
people. That's it's the scoring system they use
Oh,
for
sure.
evaluating. Oh yeah, I just kind of just like what it says, but
Okay, so it
ever
is,
higher seems
that's pretty
pretty.
high.
Yeah, it's like not like a high risk. They didn't just use like written.
On pump with or without valve. Cardioprotectant.
We didn't really talk about much like exactly what Precedex
Basically,
situation
any
was.
sort of other organism.
Yeah, I
Like
was
a
trying
drip
to see.
postoperatively. They had time extubation.
Got it. Got it. Glasses. Yeah.
Let's see.
Right now.
Yeah. Vasopressor requirements.
They're saying
so
we
clear
use
now.
something called energy dissipation pressure, and surplus in percentage.
And they call them that, well, a year.
So, big picture started after the except for like ethics or whatever.
Can't even do the trial.
So that's a huge strength.
So,
Large end.
you can't even do the 240.
One had like pump runs.
So it's funny to talk about.
That would be a more significant factor, probably.
But the president's group had a shorter pump run
Sedation they use.
for cross coach timing.
Oh, thanks, man. Thanks for good work.
But significantly more people were using a tray or a balloon pump.
Yeah. I don't know what they mean by that. Stop.
So it's triple blinded.
Like, is that they just stop because there's a bunch of different
It was,
Is it truly double blinded stuff?
Right.
Yeah, unless they're able to control for like a balloon
sham or not?
The patients?
No, the other.
No. Patients, anesthesiologists, cardiac surgeons, ICU and ward staff, and study investigators were all unaware.
Yeah. ARDS management.
Or like, yeah, how do they do that then? Like, I feel like I know. Right, so here, in my show, there's interventions.
Early NMB
Mm-hmm.
and ARDS.
Neuromuscular blockade indications.
Oh, so you just didn't know if the valve was open or not.
Methods that they used. So it's multi.
Read some slides.
Institutional.
No. I'm just,
Get 1 year.
Fair enough.
Very that. Like this.
Right.
We're patting ourselves on the back here.
I think that, because here it says, the observed reduction in the hospital, 30-day
Surgical marking.
I know.
and 1 year
So you're using chronic pain clinic. I have no idea.
receiving perioperative despentotomy persisted after propensity adjustment.
Draw like little like smiley faces on you right now if you fall asleep.
Yeah.
Just fine.
Yeah.
I almost ate his food one day.
Usually it's pretty good.
Yeah.
Is he still at keto?
Yeah.
He lost
Little
Mortality.
He gets these like pre-made lunches.
We get pre-made lunches, that sounds good.
Or no, you said that. Yeah, you're right. Yeah.
Packs it up.
Feasibility problem. Yeah. To go up to CDC is remote.
Right.
That is how they were doing it at first. They were including coronary.
Houston even measured some stuff, like blood levels and stuff.
Yeah. The biomarkers.
They've probably done it in the past, but just looking at components.
So they just gathered components on everyone?
Or like
And then they do it
I'm a little
in the
confused.
curve,
I
so
haven't
they
seen the explanation for what this
chart
condition.
the level and then just, like, sound like they just put a blood pressure cuff up for 5 minutes.
I know.
3 cycles.
I know, but that's like,
But no, it doesn't say what there.
that's it.
Yeah, so like just having like
Having an ischemic.
in like an area of the body like release like some kind of mediators.
that's like 30 hours.
I guess I was imagining some kind of causing renal ischemia, but
No.
I guess they're just going for some biomarkers.
They
Yeah,
look at
man.
a lot of things. I don't know.
My question is, why don't we use
People are
it?
staying intubated for really.
I was going to say,
Yeah.
especially with the types of cases of exposures.
Plus or minus 83 hours.
Probably because we just like
Yeah, they look at basically a lot of things. So like, they
whatever we're doing.
Yeah, so plus or minus 83 hours. 24, 30, 48.
Like, why are we doing this?
Yeah.
It's because I'm getting a blood flow to the kidney. Well,
death paradise. Coronary revascular stroke, and then they had a bunch of secondary endpoints.
made it 20% control group would have major cardiac.
I don't know what this is doing. This predicted 1 year mortality, but Like, so it's not a low propensity score. Oh, I guess that's just saying, like,
You need this in there.
I don't know. When are we presenting this stuff?
You have like
precedent.
You want to split it up?
Well, I'm not gonna finish this whole thing in 5 minutes. I'll tell you that.
Okay.
You did a 3
Where do you
minute
see
warning.
these differences?
Whoa.
Cool it.
Seriously?
Says 7.
So what I mean is just like highlight a million first sentence. That's what I usually do. And then when I have to figure out what else is said, I just.
Why don't you just look through the results? I'll just look at the anything funny with you.
But you can jump
Okay.
in and poke holes and stuff.
Are there groups of 2? I think we're missing one of the papers too. I'm not sure which one gets left out.
I have to work with him.
Not necessarily.
Yeah.
Oh, that's gross. I'm sorry, James. It's a big sacrifice. Like
I
a,
need
like a
bucket.
wild
I
animal.
need a bucket to eat.
He's aware of his issue.
Yeah.
Yeah. Different sandwiches.
Charlie, I don't know.
Jimmy John's. And
You didn't even know this. You're like, what?
Babies over the weekend.
Yes.
Well, I don't know. You need an article. Saturation.
Cardiac surgery would also.
JAMO.
I guess.
Kidney injury among high risk patients.
Inaccurate.
Cardiac surgery.
No later years. So
Can I take Aww.
yeah, is that the one you have?
One.
Yep. Oh my goodness.
And
Yep.
that's the other.
So well balanced.
Smarter.
Oh, okay.
After cardiopulmonary bypass.
Like his haircut.
Yeah.
Patient scoring system.
Hell no.
I understand why you're
Alright, we'll get what they try to do here, and that's fine. It's good.
Sure.
Now I understand.
Physics is good.
Yeah.
I would say it ultimately does
Reading
not
this
change
and
practice. Because
what else you can use.
what about the post-op renal failure?
So
Study.
Individual components of the program.
Stroke.
How much was it? How was the differences between the group there?
I was thinking there wasn't.
None statistically significant.
Was there anything changed?
Yeah, I guess it's only
oddly?
No, it's like identical. Cross-class times were within a minute. It's crazy. Cardiopulmonary bypass time was within 2 minutes.
For my 2-hour appointment.
Oh, yeah.
But they're all
Give counterpoints very easily.
good.
You could give
No, she is. She is so cool.
See him in the he is such a disaster.
one reason why we suspect.
So I don't think we have the supplements. So it's in the supplement, but it's leaving the clinics first.
This was obviously.
That's amazing.
So it's multi-center, double-blinded, prospective.
I'm married well.
My
Ischemic preconditioning studies.
Basically, no.
So, if I was ever gonna have heart surgery, I would ischemic precondition myself, like hold my breath for like a minute every day,
One
leaving
that
the
did yoga or does yoga still, right?
That's part of it, right?
Might as well, right?
Into the study.
It's probably not going to make anything worse at that point. Already have weak average.
Because they were too healthy.
With remote ischemic condition.
But no, look, they have this many.
the eligible
Like in a good way or bad way?
in a bad way.
For inclusion in the study in 195.
So I'd probably just stab myself in the
I
head.
think I want to talk about this. Okay, I'll go find you an article.
Yeah, and you gotta decide quickly, right? You're not gonna spend a whole hour one article, like. Yeah. Well, and you figure out what's important. I mean, you should be able to. It should all be very plain within the paper.
So this is all comers that they looked at, but not in the actual study.
9%
Right.
So if you have a question, right, like you can't.
Yeah, that looks about right.
414.
No, I mean, this is
The meeting.
1612.
Oh, well, no, this is.
Right, it's like, you want to see this, what do you do?
The 800 per group. Right. So,
But they never actually said.
yeah, which one they use?
It's definitely not me. Obviously.
Right, and it's definitely not me because I'm a CA too. I might want to be checked out.
Yeah.
Then you get some.
What do you need to know to understand the study? What is start to
How does it work? Just anti-cramp story.
That too.
Subcategory.
Yeah.
Yeah. It's good outcomes.
Yeah. The pedal network, they all have to be.
Right, found limitation. Basically, retrospective cohorts.
So what is it?
Well, just a limitation, but I'm sure there's no. They had no.
Something like they have. Like everyone's a flower.
Looks like they had some.
For RRT. I just left it up to
Oh, yeah.
As well. And did they randomize it all, or
Lower components.
pump time?
But it didn't actually see like a balance.
For which pump
What
time?
constitutes insufficiency, what
I mean, for
constitutes
the,
failure.
you mean like on bypass? It says,
I don't know. You gotta get creative. I don't know. Glenn's working on ours. Is this still Casper?
Yeah.
data.
And I think I fixed it
Did they
because
exclude any?
before I was
medication
getting
for
cardiac,
perspective?
A was cardiac.
Yeah.
So it should be cardiac anesthesia and surgical.
There you go. Yeah. So that, you know, there's a lot of cardiac care.
Casper trial.
It wasn't such a little morbid.
Definitely gas.
Here's the exclusion criteria.
I'll have a review of anesthesia and ski policy.
Up to 7 days before surgery, off pump surgery, pre-existing AKI, kidney transplant, chronic kidney disease, PVD.
Those are the,
Yeah.
Right. Like if they improve their surgical technique.
That's what we were wondering about too, is Casper too, like ghost, friendly ghost, because it's like, is it powered for mortality? Like, what are we?
chronic pain.
Tile or bugs? Like, there's lots
They
of
said
stuff.
they got rid of.
This might be more of the other one. You run out of flowers.
Like good pressure perfuses rain. These are real good.
What does it say?
Too good. Sploosh.
Someone providing their data.
They specify whether it's
We'll have to name it.
Yeah, they
Yeah,
excluded
for
those.
sure. On the, have you seen the acronym generators? You put in your phrase, and it'll like give you a score based on what's possible.
Oh, that's fun.
Yeah, it's pretty fun. You can put random phrases and see what you can get out of it. So which way does it work?
Right. So this is one.
You can put in whatever you words, like keywords that you want, and it'll spit out like 300 potential acronyms.
Oh, it doesn't do it the other way around, where you
Oh.
have an acronym in mind.
No.
See what I'm gonna study.
I want to
No,
call
you
this
can't.
bogus.
It-
Tell me what, tell me all the studies you could do.
It works backwards, I think. Too. All right, that's the timer.
That was just.
Time's up.
Yeah, so there was, I don't understand why, but there was data missing from a section of these. And so when they measured it just
Finish
with
up
the
your
people that
thoughts
had
here.
the
Worksheet.
data,
We'll have the
there
first
was
group present. And
Get us it over there next.
yeah,
Did you want to write?
I don't know if we have all of them, but I have them up here. I can put them up.
Better not be, because we're the last group to show up.
Just,
Yeah. All about my day.
just remind them that we're the last group.
It's best for you or for them?
Pretty question
Why is
that
it best for me?
is really difficult
Yeah, we got it.
to answer, and then they do a score analysis that's based on ridiculous assumptions.
That's the nature of the beast. That's how you play the game of the fundraisers. Play it all the time. You have to, otherwise you never.
Yeah,
You have to
that's true.
pretend you know what you're doing, so people will let you figure out how to learn what you're doing.
I'm moving on Saturday, not start CT again.
Not improved as well.
Exactly what we would say.
And I work Saturday night.
So I feel like
Will
this
not change.
Yeah.
Do what you gotta do. We'll have a wet.
Hold on.
That's really cool.
We're ready. I think we're missing one of the papers, but let's start with the. Is it Erica trial?
Oh, that's us.
You guys? Pretty well, so I think you're first. Just get warmed up.
This went pretty well.
I know this one pretty well, so.
Oh, good.
Yeah.
Me too.
Oh, what?
This is my fourth time reading this article, so.
Helps me see
All right, so the way this works is you sort of go through your sheet as a format to present sort of the evidence.
You guys didn't pass that any
Guys,
further than
the
right there?
sheets.
Come on. Good job,
There's a
guys.
stack of
Solid.
sheets right there. Oh, thick Nikki.
That was really nice. Appreciate that.
So we're gonna come up with this in real time.
We got this.
We can come back to you too.
No, it's fine.
Now it's
We
cool.
got this.
You guys can
All right.
handle it.
Sabotage.
You look ready.
We are ready.
So you can use that as a prompt just to say, here's what we need. Basically, none of us have read this paper. Actually, most of the people in the room haven't read this paper. So try and make a case for why you think this should or should not change your practice.
All right, so this study, remote ischemic preconditioning on cardiac surgery. And so the idea is that if you have a preconditioned ischemic event, specifically, say, a blood pressure cuff that cycles on and off a bunch, you could potentially decrease the amount of end organ damage by having this preconditioning in the area of cardiac surgery, or in other surgeries as well, but specifically they were talking about cardiac surgery, and they had mentioned a previous study of where this had decreased the amount of myocardial injury by doing this kind of ischemic preconditioning.
Yeah, what you need to know is that there have been other studies that have shown that there may be a protective effect, just to summarize. And the methods, it was a prospective randomized control multi-center trial comparing this technique where they inflated the blood pressure cuff on half the patients and deflated it several times over the course of the cardiac surgery, and they compared that to a sham controlled situation where the blood pressure cuff sounded like it was going up and down, but the valve was open. So, and it seemed to be triple blinded. It was blinded to the patients, all of the providers, and the study investigators on whether or not they actually got the sham or the actual treatment arm. So it was seemed like it was a well conducted study, powered appropriately and
And that was the
designed appropriately.
only part of it that was structured for the team. So the rest of the anesthetic management was per the providers. And it was pre-induction. Yeah.
Okay. So I'm totally unfamiliar with this paper.
Wonderful.
So
Well, for now
So
you're
I-
very familiar with
a couple
it.
of
That
questions
summary.
pop up right away. I always like looking at the hypothesis.
Uh-huh.
So it's cardiac patients, and then also looking at how they designed it. So why cardiac surgery?
Let's hear the results and whether they think it should change, and then we'll see.
Yeah, but I
qualified.
mean, I haven't even looked at the results yet. So I don't know the results.
You already have questions.
I already have questions.
So present everything you think you need. Tell us what happened,
All right.
and then qualify it, and then we'll sort of question, and then you guys make your case, and then questions, and we'll fill in the blend of
Okay.
that. So we have the full
All right.
picture.
All right. I'll keep my
Lay it
mouth
all out there, and then we'll come back to that.
Okay.
So what happened? What did they find?
Great. So the primary outcomes of the study, the primary outcome was the major rate of adverse cardiac cerebral event within 12 months, or at 12 months, at a year after randomization. And there were some components within that primary endpoint, which were death from cardiovascular causes, non-fatal MI, need for new revascularization or stroke. And there were a number of secondary endpoints that basically were evaluating other signs of end organ damage to the kidneys, perioperative myocardial injury, etc. You want to tell me about the results?
Yeah, so the results of the study, first off, the randomization between the two groups, they looked identical. There wasn't any differences between the groups, at least that was statistically significant, and nothing even seemed to be trending one way or another as far as that goes. For the primary outcome, so they did an intention to treat analysis, and the primary outcome again being adverse cardiac or cerebral event. At 12 months, it was essentially identical. There was no change in outcome in the primary outcomes. And then for all their secondary outcomes, which we could go through each of them individually, but the big thing to pick out is just that there was no change in any of the secondary outcomes. One of the outcomes where they did see a little bit of change, which is a little confusing to me because I need to kind of get into the weeds a little bit more on this one, but was they were looking at the myocardial injury. by looking at troponin trending and then area under the curve after surgery. And it seems that some of the patients didn't have the complete data set, and so when they did the intention to treat essentially analysis on everyone that had it, there wasn't a significant difference. But when they just looked at the patients who had the complete set of data, they saw maybe a decrease in the amount of troponins for the people that were preconditioned. But other than that outcome difference, they didn't see any change in any other secondary outcomes, and that included stuff like ICU stay, inotrope use, kidney injury, hospital stay, things like that.
Yeah, so the major strengths of this study was that it was a well-designed, prospective, randomized, controlled, triple-blinded, multi-centered trial that was powered well and included 1,600 patients. And another strength I felt was that these patients in particular were sicker cardiac patients. They had higher Euro scores, on the higher end of the Euro score, so it certainly seems like something that could be applicable to our practice, considering we take care of fairly sick cardiac patients. And it was looking at a new group of evaluating a new type of patient in terms of this question about whether or not pre-ischemia or pre-ischemic conditioning affects outcomes.
Another strength of this as well is they had very low dropout rate. So they accounted for this study like 4.5% dropout, and they only had like 3.5%. So they were able to power it appropriately, and they had a good follow through with it. Limitations of
But
this.
the follow-up too was at a year, so it wasn't just like a month and then, oh yeah, some of them are doing well. They really followed them out for a year, and again, did not have much dropout at a year, got most of the patients at a year.
Limitations for this one, I didn't look at what they said for limitations, but if I were to kind of interpret my own, overall they did a really good job with this. There is a section in there when they're going through the methods that seemed like, I'll have to have you explain this to me, but there was a large number of patients that were eligible for the study, and yet only half of those eligible patients got randomized. So how that would affect the outcomes is interesting, but that being said, the demographics between the two groups were still similar, so I don't know how much that would impact that. And the other piece would just be, where do they expect to see this improvement in outcome? Is 12 months enough to look at, or is this something that we need to see like longer term on? But I couldn't really find, or shorter term.
The other limitation was that their anesthetic management was up to each provider. So that certainly, we are all familiar with the fact that each of us do things differently. And so that was not standardized, but that'd be very difficult to standardize.
Yeah, and that being said, they still did a group analysis for the different types of anesthetic to see if they could tease out any differences between that too, and they still saw no change in outcomes. So this would not change our practice, and kind of based on the results of the study, the strength of the study, yeah.
Okay. Questions?
Is there previous data that says that if you squeeze on somebody's arm before cardiac surgery for 5 minutes, that would have a systemic response, or they're testing that?
Yeah. No. So
there are some, but we just didn't get a chance to get through 8 through 10 on the references. Have we gone through 8 through 10 on the references?
Peripheral ischemia improves.
Yeah, what they had done in prior studies is inflating a cuff, leaving it inflated above the systolic blood pressure for 5 minutes, bring it down for 5 minutes, and repeating that for a total like 4 or 5 times prior to surgery. And so they had done that in prior studies and showed decreased myocardial injury, but no one had looked at primary clinical outcomes as far as that goes. And this was also specifically aimed at higher risk populations. So the Euro score of 5 or higher means these are pretty sick patients that they're doing this with.
Yeah. So back to your point.
Well, and the other point there on that is, and I don't know how many human models, but in every animal model, the absolute gold standard for protecting an organ, whether it's the brain, the heart, the kidneys, is ischemic preconditioning. No other drug, no other anything works, and it's absolutely astounding how much protection you get from preconditioning with ischemia.
Right. So I guess our job then is to convince you that you should be doing this for everyone, right? So you guys said it doesn't change your practice. I guess reasons to do remote ischemic preconditioning. That's one. It works.
Well, it
on
works
these models.
when it's localized, whether it's remote. That's what they're. So is there something magic about just having ischemia someplace?
Yeah. So
Not magic.
The other part is it doesn't cost anything. Pilot trials showed that there was a benefit both they had a mortality signal and a troponin signal in 300 patients. The other part is we can't rule out that anesthetics interfere with it. If it costs you nothing and it could potentially benefit your patients, and this trial showed that it's not dangerous, right? Were they worse off? Everything was exactly the same. And we've got a soup of anesthetics in there that could be interfering with it. So is there a reason not to put the blood pressure cuff up?
Well, this is specifically just this one study. We haven't reviewed those other studies, so without that prior knowledge at hand, I'm going to say.
Just based on this paper.
But I mean,
Just
also
based on
based
this
on that
paper.
logic, like there's a lot of things that we could do that may not hurt the patient, like whispering in their ear. You're doing really well, but we don't know if that's going to change their bleeding. Like you could put 2 different colored socks on them, and that doesn't really hurt them, and that also doesn't help. So we don't really know.
You could
I mean,
argue that OR
there's
time
sort of an infinite amount
for
of
doing this.
possibilities of that argument.
So it's well designed. And actually, this was published with a companion paper that was done in Germany, equally as large. They published them at the same time, and they got very similar results.
Was that ours?
Getting back to the double-blind stuff, and because I think we've got some others that are setups for proving the negative, which is what this one does. So one of the things is, and they're kind of vague about it in the intro and the hypothesis statement, but they've done a couple of things. One is they're going after major bad outcomes.
Oh, the composite, that's right. And it's a whole soup of other things that they're looking at.
But it's major stuff.
Yeah.
So I mean, so if it's going to be major, you have to pick something where bad stuff's going to happen. So it's like cardiac surgery. Okay. So they're looking at any kind of ischemia, but specifically cerebral and cardiac. And the second is for just about any double-blind study, what is considered statistically significant? Not statistically, clinically.
Yes.
So almost every study. So you said death. Well, how many do you have to save? You said the power analysis was awesome, but all these studies power to the same thing. Basically, it's somewhere between 25 and 33%, or nobody's going to bother doing it. So they powered it right in the middle, 27%. So they have to show a 27% improvement in people who are,
It's a massive effect size.
It's a massive effect size.
Even to do this multi-million-dollar trial. Just because we have 4 more groups.
Yeah. So anyway,
Sorry,
that's.
I'll try and,
But you're going to see this come up on some others. It's massive effects.
yeah, that was pretty rock solid, guys. I don't know. It's pretty good. All right, who has the other remote ischemic preconditioning?
Yeah, like a little stroke.
I'm going to set the timer.
They're stroking out.
Less detail, we already have some background. Maybe a new partner. Do you want to do all of them, maybe 5 minutes to make your case?
I'll do the first 2.
Since you already know what remote ischemic preconditioning
Yeah, so, effective remote ischemic preconditioning on kidney injury among high-risk patients undergoing cardiac surgery. What do we need to know? We discussed ischemic preconditioning, as well as the fact that in this paper highlights kidney injury. So specifically, kidneys we all know are pretty high risk during cardiac surgery. And They quoted up to 30% of patients have some kind of AKI. So they looked primarily at that, but had some secondary endpoints. So moving on to the methods, this was a multi-center, double-blinded, randomized controlled trial, prospective, obviously. They were able to randomize 240 patients out of 790 that they screened. The exclusion criteria were acute MI up to 7 days before surgery, pre-existing AKI, kidney transplant patients, CKD, pregnancy, PVD involving the upper limb, which is where the ischemic preconditioning would occur, and then
Diabetes patients on sulfonylurea.
yeah, diabetes patients with treated with sulfonylurea. So going through the primary and secondary outcomes, as I mentioned, kidneys were primary focus here. So the primary outcome of this was AKI after the first, or within the first 72 hours after surgery. And this was defined by the Kidney Disease Improving Global Outcomes criteria. The secondary outcomes included severe AKI, 30-day all-cause mortality, duration of ventilatory support, ICU length of stay, and in-hospital deaths. So the result.
Sure. So for their primary outcome, they did show a significantly reduced amount of people that were getting AKI within the first 72 hours. They say it's 37.5% in the intervention group versus 52.5% in the non-intervention group. So both of them still had high numbers, but there was a significant difference. They said it was an absolute risk reduction of 15% and a overall risk reduction of 28.6%. In all of their long list of secondary outcomes, they showed no change in most of them. The biggest ones they showed changes were reduced severe AKI, which makes sense. If you have reduced AKI, you're going to have reduced severe AKI. Reduced use of renal replacement therapy and reduced ICU length of stay. They also showed reduced biomarkers of AKI, but they have this long explanation of like who's going to have the biomarkers and who isn't, and that's why they excluded the sulfonylurea people. And I don't know.
Not as essential.
I don't really care. Yeah,
It doesn't really
clinically.
I can
cause effect.
do it when we get back.
So, do you want to talk about some limitations and things?
Sure. So yeah, limitations of the study. So we talked about the exclusion criteria already. This was patients that were undergoing cardiac surgery. They described that they had kind of like large parameters for the bypass and the cardiac surgery, but it wasn't like closely defined. So like map between 60, 70, didn't have like a specific pump time, anything like that. Anesthetic management was left up to the provider. Decision to go on to renal replacement therapy was left up to each individual provider. There's many comorbidities that could be confounding it. They had a protocol for AKI, but not other secondary outcomes. I can't read that.
Sorry.
Oh, you're good.
I think another thing was that obviously the primary endpoint was powered correctly, but all the secondary endpoints weren't. So, right, especially with mortality, like you were saying, that's a big event. Death in hospital death, you're going to need a lot more than 240 patients to tease that out. But I think as far as their primary endpoint, I'm more or less
So how is this score created?
What, the Kadigo?
Yeah.
This is the standard.
Yeah, what is, I mean,
Yeah.
I'm sorry.
How is the what create?
what is that?
What is?
What do they measure? Is it creatinine mainly?
That score.
Oh, that whole, yeah, they have this list of
It's the biomarkers or death.
No, that was
It's on the
the.
table. Made up score.
Did they even include it in here?
No.
No.
They reference it as,
They
as
reference-
an image, but I don't know if they
Yeah,
actually have
this
it.
image, the image was not in there, but
Yeah. So I mean, we didn't
Creatinine
get a
bump
chance to look up what
over,
their-
50%. Yeah, it said per the what do you call it? The
It's like,
Kidney Disease Improving Global Outcome criteria.
yeah.
That's it.
That one.
Oh yeah. That
We didn't
one.
look that up.
So blood pressure cuff,
Blood pressure cuff
yay
up
or
for.
nay? Would you do it based on this paper?
I mean, based on these two papers, I think as far as what you were saying before, harm to the patient, minimal. Potential benefit, seemingly maximal.
So building on this, how did a really expensive, well-designed trial that had 10 times as many people miss it? Saw no signal in anything. Didn't improve these long-term one-year outcomes. And then this 240 patient trial, also well executed, got the opposite answer.
Yeah, and they even mentioned 3 other trials that also got the opposite answer that seemed to be powered better than this one. And creative math.
No, I think it's real. I think they looked at the right thing on the right people. You know, cardiac surgery and kidneys.
How many studies do you have to do identically well to get a positive result if there's no difference?
Another way to ask that too is if your p-value is 0.04, what's your chance of having a significant result again?
By chance.
By chance. The short answer, it's a coin toss. It's 50-50, whether your point is like at that level. So these are kind of crude instruments that we're using. You can miss it even though it's an enormous amount of effort and it's considered the gold standard. Any disagreement? These
If
are
something's
both
wrong,
incredibly-
if some of them aren't positive and some of them aren't.
Right.
If there's an outlier, somebody's cheating. They make them all come out. So, I'm just kidding.
Okay. We have 2 more groups that I agree. Well designed, got the opposite answer. They picked maybe a more sensitive indicator and then powered for that. And then you guys want to present now just so we can get everyone get a chance.
Sure.
Yeah.
So we had this meta-analysis of renal function after adult cardiac surgery with pulsatile perfusion. So the things that you need to know are that CABGs can be performed either pulsatile or not pulsatile flow. And you need to know, well, at least after reading it, what is effective pulsatility, I think. Do you have anything else to add to that? They used a meta-analysis. They searched 3 different databases using different search terms: pulsatile flow, pulsatile perfusion, cardiac surgery, cardiac surgical procedure, and CABG. Eligible studies were ones that evaluated post-op renal function, like acute renal injury versus failure after pulsatile and non-pulsatile flow. So they selected trials that were randomized, that had original data, and that had enough data for them to calculate a mean difference. They found 364 total studies after excluding for irrelevance and duplicates. They ended up with 9 total studies, including 13, almost 1,400 patients. And they were almost equally split between pulsatile and non-pulsatile.
Yep.
And their results showed that post-op creatinine clearance was increased in the pulsatile group and had a decrease in acute renal injury, but there was no difference in acute renal failure between the pulsatile or non-pulsatile group.
Yeah.
Talk about the strengths.
So they defined acute renal insufficiency as 50% increase over the preoperative creatinine value within 48 to 72 hours. And then failure was defined as requiring first-time hemofiltration or dialysis. So it was powered well, and their results were significant to indicate that pulsatile bypass is better for creatinine clearance about 2 days post-op. But I feel like beyond that, things started to just sort of become the same.
Yeah.
Strengths, I mean, they did a lot of work combing through all these studies. And then we talked about significant power.
Yeah. Are there enough studies to really answer
No,
this
I mean, the other issue too, there was a lot of heterogeneity too amongst the studies that they used and the patients focused on within those studies. So they tried to do calculations to make up for that, but some of them didn't quite make that cutoff. Other limitations, they only focused on cabbages when they said the effects
Higher
of
risk.
renal injury after cabbages is lower than a cabbage and a valve, which has the highest incidence, and that was totally ignored.
Yeah.
Would this change my practice? I mean, sure, why not? It's more physiologic, right? Other than that,
I would say no, it didn't make any difference in acute renal failure. So like you're just like getting better numbers, but I don't know if it's.
that's true.
really
You look
making a
better for a
difference
couple days
long-term.
after, but not maybe beyond 2
So, and like
days.
I don't know how much it would cost to like change out your system to make it, if you didn't have a pulsatile system, like would changes in some numbers that look better be worth the cost of changing out your whole system when they have an equal chance of going into renal
And they
failure,
weren't
which is the most significant
super
thing.
clear about what's pulsatile.
Effective
Which was
pulsatility
really annoying.
versus.
That's a key. So,
Yeah.
little background on that. There's 700 or some odd patients in this.
Yes.
500 of those come from one study where they put a balloon pump in before and ran it during bypass. So that gets the heterogeneity. That was the big point of this paper is yes, but maybe, right?
Yeah.
Because there's a lot of other things that go into it. The heterogeneity, when you look at a meta-analysis, which you guys zeroed in on, that's what I was hoping you would do. If there is a big heterogeneity, you have to be careful with the results, whether that's helpful or not.
Yeah.
Okay. We'll go to the next group and then maybe just talk about all of them in the process. What do you guys?
So we're.
Wait, there's 2 more groups.
Two more.
What?
So we did get that. Yeah.
Kimberly's point, which is where I was trying to head with that test you were talking about, is always ask, like you did, is this a process variable that I can show a difference on, or is it an outcome? So, anyway, just keep that. So and which one's easier to get data? Well, process variables are easy to get because they're in the chart often.
Yeah.
And outcomes usually aren't in the chart, but they matter more. So if you're doing a study, process variables, very tempting.
You guys convince us in 2 minutes?
Sure, why not?
This one probably.
You should probably use dexmedetomidine in heart surgery. So we did perioperative dexmedetomidine improves outcomes in cardiac surgery. Basically, what you need to know what are the major postoperative complications of heart surgery and the contributing factors. They thought that, with surgical stress, you have an increase in epinephrine, norepinephrine, and that increases this myocardial oxygen supply demand imbalance. And so they thought that if you were to give a alpha-2 agonist, you could decrease this demand and improve outcomes. So this was actually a single-center retrospective cohort study. It was over a 5-year period from January 1st, 2006 to December 31st, 2011, and it was reviewing both CABG or valvular surgery or CABG or valvular surgery with a combination of another procedure as well. And they basically had 1,200 patients and split them into 2 groups, so about 600 each. One group got dexmedetomidine, and what they defined giving perioperative dexmedetomidine was intravenous infusion of 0.24 to 0.6 mg per kg per hour, and that's initiated after coming off of bypass, and it was continued for less than 24 hours post-operatively in the ICU.
So like 30 hours, plus or minus a huge range.
Yeah, pretty long. So basically, they kept everything else pretty much the same. They had a standard monitoring, general anesthesia. They all got midazolam. They either had an induction with propofol or etomidate. They either had fentanyl or sufenta, lidocaine, rocuronium, and they were maintained on oxygen and SIBO. And then, let's see, they looked at 30-day mortality and 1-year mortality, all-cause mortality, and then a bunch of secondary outcomes, liquid mechanical ventilation, post-operative renal failure, new dialysis requirements, link to the ICU stay, link to the stay in the hospital, 30-day readmission, and blah, blah, blah.
So their results, they included 600 people in both groups. When comparing the two groups initially, they found that the dexmedetomidine group had a higher incidence of a history of an MI, a history of congestive heart failure, and that was pretty significant. It was 31% of patients in the dexmedetomidine group had a history of congestive heart failure versus 7% in the non-dexmedetomidine group. They found they had a lower ejection fraction and a higher incidence of renal failure, as well as they were on medications for dyslipidemia at a higher rate. So I'm not sure that groups were necessarily comparable, but anyway, they also, so their major findings basically were that in-hospital mortality, 30-day mortality, and 1-year mortality were lower in the group that received perioperative dexmedetomidine compared to the group that did not.
So the Precedex group is sicker
Yes.
and then dies less.
Yes.
Does that make any sense?
Not necessarily. Maybe if the Precedex is doing what they maybe say it is, but
That's why this paper's in circulation. Yeah, go ahead.
yeah. Other than that, they didn't find any differences. They didn't find any differences between. They say the perioperative use of dexmedetomidine was associated with a significantly reduced incidence of postoperative sepsis and any complication, but no differences were seen in the incidence of major adverse cardiocerebral events, delirium, postoperative ventilation time, which was 30 hours for them on average between the groups, and then total length of ICU stay, length of hospital stay, and that's it. So their biggest findings were reduced in hospital 30-day and 1-year mortality, and they were sick. So,
should this change your practice?
Since we already used Precedex perioperatively, no, but I think if you didn't, you should.
Is a retrospective study good enough to change your practice? I mean, the gold standard are these prospective, multi-center. You're telling me that 600 in each group got this. You did a chart review, and then I'm supposed to use different medication.
Yeah. I don't think that, sort of like we talked about, I don't think there's a reason not to use dexmedetomidine. And it improves, I guess they didn't show delirium, but it's helpful, and we found that for lots of different areas. And so,
also doesn't change your hemodynamics as much as some would argue.
And are these retrospective chart reviews, are the intent of them to change people's practice?
maybe not. It may be more of a descriptive.
Or to a real study.
Yeah.
Although the effect size was so big,
Yeah.
you could make a case that this was.
So no further studies are needed.
I don't know. I mean, there's always further study needed. But,
I think somebody's going to run with this.
well, yeah, people did run with it. Like it's you probably didn't even get a trial power.
Yeah, and sort of the way they use Precedex, and it was a little unclear on how long into the ICU stay that they used it. It was unclear. I mean, these patients were intubated for a really long time. And, so I agree controlling it, running for a certain amount of time.
Nice. Good. Okay. Last group, you guys?
So this one is called early neuromuscular blockade in the acute respiratory distress syndrome. So what you need to know, there's currently an unknown benefit of using early neuromuscular blockade as a standard for people with ARDS. There was a study that came out like 10 years ago that showed there was a benefit. But obviously if you have people on neuromuscular blockade for longer amounts of time, you need more sedation, so there's downsides of that. And despite that study, it's still not using early neuromuscular blockade is not a commonly adopted practice. And so this was a multi-center randomized prospective cohort study that looked at whether using standard early neuromuscular blockade in ARDS has benefits or not. The short answer is no. So they found no difference in any of their endpoints. Their primary endpoint was in-hospital death after 90 days, and they found remarkably similar, or I guess no difference, like the numbers are pretty much the same in both groups. And then they looked at secondary endpoints like organ dysfunction, in-hospital death at 28 days, days not in the ICU, days off the vent, and then some other things like disability, quality of life, PTSD, things like that. They found no differences in any of their primary or secondary endpoints. And Nick will talk about why.
Strengths, I think it was a good study, large and good methods, and it had clinically significant outcomes, so mortality, or 28-day, 90-day mortality, days free of ventilation, days out of the ICU, and days out of the hospital was secondary outcomes, so clinically important. Limitations, we already kind of talked about sedation as a confounder, so if you're laying in bed paralyzed for 2 days, you're not going to be you have increased risk of delirium. You're getting high dose of sedation, and we know delirium is going to cause changes in mortality. Also, in these patients, they had a high PEEP, so they had to have, it was a P to F ratio less than 150, so moderate to severe ARDS, but the PEEP had to be 8 or higher. And then the previous studies in the ACUSIS study, which was the one that showed a 10% reduction in mortality with early paralysis, they didn't have any defined PEEP values, so this was showing that maybe the PEEP is the benefit here and not necessarily the paralysis. Will it change your practice? No. I mean, currently we only use paralysis kind of as a last-ditch effort in severe ARDS with nothing else, so we wouldn't just put everybody on paralysis from the get-go, or within 48 hours of the diagnosis was what this looked at. So that's a wrap.
Nice.
Mm-hmm.
But their rates of delirium weren't any different.
They actually didn't mention that, which I was surprised by. They did say
and
it showed
ICU
weakness.
length of stay was the same too.
Yeah.
Yeah.
Like the stay length, days free of mechanical ventilation, and then days like how early before day 28 were they discharged for the discharge.
There was increased rates of ICU acquired weakness, but
that makes sense if you're paralyzed.
Right. But at day 28 and time through day
How
28.
long were they on average paralyzed for?
It does sound off the top of my head.
Don't know that either, actually.
And the control group was paralyzed?
Some of them were.
Well,
so
some of them,
there
I
wasn't
think
like
it
a
was
set criteria. It was just if the clinician thought they needed to be paralyzed, they would be paralyzed intermittently, but not with a continuous infusion.
Well, I think it's because like the average dose of paralysis one, it was like 48 milligrams in like the control group, and then like not an infusion. So it was just like a one-time probably for intubation, or like a one-time dose if they were agitated or something, but not like a continuous infusion.
As you do. You know, the news. Oh, that clarifies.
Good.
Now we know how you roll.
Just whisper, I'm sorry, and push the ground.
Okay, so I think everyone did a really good job of doing, looking at a paper they hadn't seen before, getting to the heart of what you need to know, and then trying to draw some sort of conclusion. Hopefully the new format of the Journal Club has helped make that easier to like, what do you need to look for? Because this is what it's going to be like in practice. You have a question, go grab a paper, try and dig through the literature a little bit and get as much as you can quickly without getting caught in the details. Sorry, it was probably too many for this session, but I just wanted to go through and get everyone a chance to, under pressure, get an answer and go. So this is what you're going to run into. I also wanted to highlight that you can get a different answer depending on how you ask the question, and that clinical trials, even the best of what we have, is still a blunt tool, right? Because one, depending on what question you ask, usually they're only powered at 80%. So you're gambling anyways with millions of dollars study, but it can miss it. And it really depends on what these outcomes are. Same thing with a meta-analysis. There may just not be enough data to tell, but you might have a signal. So more needs to be done, or if retrospective looks really, really promising, it can at least nudge your practice, if not completely change it. And these are the sort of the main study types that you'll see that can be informative. But still, the gold standard is going to be a bunch of trials that look at it from a lot of different angles and get into that. So any thoughts about the process, or just anything that came up in doing it, or the helpful to kind of go through under time pressure? It's more fun than doing it ahead of time, I think. And we can refine it more to bring up the battle aspect next time with prizes. But I thought really nice job at getting. I think you covered all the points that I wanted to get to with that.
Yes. Knowledge.
And you guys got the award for like fastest at the end.
Nice, proud of that.
Yeah.
Yeah. Blah, blah, blah.
Blah, blah, blah.
Any study types missing that we haven't covered that you feel like you've run into that would be helpful? I try to pick the most common ones that you'll see. Most of the clinical research is coming from. Can you think of any that?
Non-inferiority.
Yeah, I was
Yeah, we
thinking
should
that.
do.
Yeah.
I thought we did one, but I'm not sure.
We did.
I think we
doing
did one
last
earlier,
Oh,
but
yeah.
they're tricky.
Okay. Yeah, that
Not
might be
this
a
year.
good one. So different trial designs maybe. So just a little bit of backdrop. The NIH in particular is growing weary of all these massively expensive trials, like the 2 remote ischemic preconditioning ones that were null are a huge resource-intensive undertaking. So the way the field is going in general in medical research is pragmatic clinical trials. So there's 2 things that they study. One is efficacy, and so does this intervention work in the perfect group under perfect conditions? Those are tremendously expensive, resource-intensive, and a lot of times they'll fail when they go to real-world practice, which we've all seen. And that's an effectiveness trial. So there's a difference in those, and that effectiveness is if you take your regular day in the OR, is this going to help your average patient or a whole population? And the NIH is moving towards efficient, creative clinical trial design, meaning that you just take data you're already getting in Epic and you increase the power. So you'll accept a messier trial that you can get cheaply and efficiently. So like the Be-Free trial that's going on right now in Canada, they're going to do 16,000 patients, and they're going to randomize to no benzos in cardiac surgery versus usual care. And so they're going to have some crossover and some issue with that. But the whole thing for 16,000 patients is only going to cost like $450,000 instead of like $10 million, like some of the big pharma. So the way that it's moving is more efficient and more adept clinical trials instead of these definitive, giant, expensive studies. There's a couple ways they're going to do that. One is like an adaptive trial design. So you set up your whole trial and then you start with 4 treatment groups and then you have ones that compete. So you do interim analyses and then you drop the ones that don't work. So you don't have to start a whole new trial if you're wrong in the beginning. So that's one way that they're getting at more efficient trials. The other one is like a cohort. Basically, you do the same thing you're normally doing for your patients, and you follow all of them the same, but you take a subgroup and then randomize those and reference them to the control population. So people are realizing this is a problem, because a lot of times we'll have questions in clinical practice, like, well, there's no trial, so we don't really know what to do. So they're trying to make that less. And the other part is like for dexmedetomidine, it's off patent. No one's going to pay for that trial, even with a reduction in all-cause mortality of 0.3. Which is basically like a magic bullet in clinical medicine if you've been following these effect sizes. So some of that is like if there's not someone willing to write a $10 million check, you're not going to get that trial. So they're trying to find a way to more practically get it. So that's some of the things you'll see coming down the line. That's a move away from that traditional gold standard.
Yeah. There's a few people also have a dream of mega data.
What's that? That sounds awesome.
Well, that all data is available or can be accessed, and so the example. This is Sachin Catterpall. His idea, he's been spouting for a number of years, that where he wants things to go. It's where MPOG got started, and the idea is that it'll become like there's enough data out there that we can Googleize it mainly. So, for instance, you can use Google, just look up data to track spread of influenza. Because there's so many people that you don't need statistics. Who's looking up, fever?
Right. So yeah, they can detect outbreaks if they know where you are and you're Googling like chills, like I can't get out of bed, and they're like, oh, there's like flu over here, So when you have hundreds of millions of data points,
and in election cycles, Google does as well as any poll. So there's massive data. There's enough data. The idea is that you don't really, it beats statistics. And so I think, the problem is getting it all in one place. Because the insurance companies hold a lot of it. And anyway. But yeah, I think there's going to be more of that. Where Sachin says things are going to become Googleized, and you can ask a question and get an answer if you have the magic kind of query.
Yeah.
And you can track these things.
Exactly. So that's where the field's going. There's just by your daily practice, we're generating mounds of data. So it's getting to it and being able to ask and answer a question with it. But yeah, so don't be too tied to just the methods of what it is. Just how do you ask a good question? How do you get an answer and evaluate that when someone else has done that work in the literature? But hopefully that's helpful. And nice job. And we'll refine this a little bit as we go. All right. Thanks very much. Sorry for taking you long.
We got a reading research in our class.
Sarah's last. Yeah.
Oh, that's Sarah's new one. I was like, she's the luckiest Woodward. I was very confused.
Oh, sorry, Bethany.
How did you get married? You got